Okay, we'll start. Good morning, everyone. So 1 hour to do a board review, it's not enough. So I try to squeeze as much information as I can. Only high yield topics for the oral exam. This will cover second year, third year, as well as البورد. So البورد يحتاج details أكثر. بس إن شاء الله we'll cover it in this review. So we'll try إنه تكون interactive. لكن بسبب قصر الوقت ما حيكون interaction كثير. So we have R1, Dr. Saeed. If you can tell me what is the anterior lamella composed of, the middle lamella and the posterior lamella. طيب, skin or orbicularis. Okay. What about the middle lamella? What else? لا, مو tarsus. Middle lamella. So orbital septum, retractors, and fat. What about the posterior lamella? Okay. Okay. So I always ask this question, and even senior resident, they don't know, they forget it or they don't revise it. So how many fat pads do we have in the upper eyelid? 2. Okay. So نكمل يا سعيد. So what are they? What's the name of the middle? Okay. And what about laterally? Is there any fat pad? What is the structure seen laterally? تمام. What about the lower? Okay. And the inferior oblique is located in between which fat pads? Okay, medial and middle. So you can see here the path of inferior oblique. So usually the medial fat pad is pale, and the central fat pad is yellowish. It's important. This is an important sign to distinguish it intraoperatively. Okay, so we'll start with simple ones. Dr. Arwa, what is the spot diagnosis? This patient came, a history of swelling, then he developed this fleshy lesion. So what's the spot diagnosis? Sorry? No, short time. What do you have? You ask a question and you get stuck. Don't do that. So what do you mean since birth? Is there a lesion similar to this kind? So you don't ask something, but you get yourself in trouble. Okay, so what's the spot diagnosis? Rahman. Okay, and what is usually the causes of biogenic granuloma? Okay. So, what else? Okay. And what do you think is the cause in this? So either from chalazion or after chalazion. Okay, excellent. So treatment usually, sometimes you can shrink it with a short course of topical steroid, like Toprodex or Maxitrol, and you remove it after. But the most important thing to mention is identify the cause, you address it, and you excise it. Okay. Again, this is high-yield topics. Mohammad, spot diagnosis. So this is very common oral question. That's why specifically some programs, they like to bring this disease. So what is the mode of inheritance in xeroderma? Is it? طيب, what is the mechanism or the pathophysiology in this disease? They have DNA repair. Okay, and this patient came to your clinic. What will you do? So apart from the ocular exam, all of this, we know that. What will you do in terms of screening? So this is a regular patient that you see, and you have to screen him every now and then. Mm-hmm. What kind of skin cancers? So you need to screen the patient if he or she developed any new lesions. Okay. So as you mentioned, defects in DNA repair, it's autosomal recessive, and they are at risk of cutaneous cancer. Another popular disease that they like to bring, Aziz, what's this? Ichthyosis, you can go back to the academy. There's a lot of variants in the academy that you should know, because some of them it's X-linked, some of them is autosomal recessive, and each one has it's a specific phenotype. And the treatment usually, so there is some ectropion in the lower eyelid. So how would you treat this ectropion? تذكر هذه قلناها، لا تقولها أبد، ترى تنرفز ناس كثير. تمام. So what's the type of ectropion in these cases? Okay, so there's shortening of anterior lamella. Okay, so sometimes if there's too much of a shortening, tarsal strip alone may not be enough. So what are the modalities? Anyone? Okay, so you're taking a skin graft from the patient who already have a diseased skin. So theoretically, yes, but it may not help that much. What are others? Sorry? You mean skin expander? Okay. Of course, this is a rare disease, so you don't expect. This is theoretically, it's an excellent option, but there's no. I'm looking for a specific question that is already there in the literature, because this is what will be accounted for in the oral exam. So, anyone? So one of the recent studies about this, they used filler, hyaluronic acid, it's effective because it's the same way as you mentioned. You're expanding the skin, and arguably you're gonna push the eyelid above, and hopefully it will correct the lid retraction and the ectropion. But again, it's temporary. But filler is an option. It's a rare disease, so there are specific treatments in the literature. Filler. What else? In the Professor Hibani, he published a case. Do you know what was the intervention? So it was mucous membrane grafts. Okay. So one of the options. So when you can mention the mucous membrane graft, there is any other option, as we mentioned, filler, mucous membrane. There is but it's not in the eyelid. They took the first 3 months from the maternal, from the mom. They took skin graft. It's a limited case report, and the foreskin of the child at from the first months before it got affected. But mainly, just to mention mucous membrane graft, filler. Of course, before that, as Abdulaziz approached the patient nicely, you see the cornea, and accordingly you tackle the problem. Temporary tarsorrhaphy, permanent tarsorrhaphy is an option also. Okay, now, so Abdulrahman or Khan, what's the spot diagnosis? So how would you approach this patient? What are the things you're going to ask for history? So you expect the duration to be long in this? طيب, examination. What are the most important things you can check? It's full-blown malignancy, as you can see. The signs of malignancy, you can describe it when the slide is presented to you. So what are the signs of malignancy? طيب, examination, what will you look for? Okay, excellent. So you're gonna see the posterior extent, because if it's going to the conjunctiva or to the globe, this indicates deeper invasion. So we're talking about something else now when it comes to surgical intervention. So it's very important to, and you can see here what's near. What are the vital structures near this neoplasm? Lacrimal gland. So lacrimal gland is an orbital, intraorbital tissue. So possibly there will be a quick track to the orbit through the lacrimal gland. Just quick detour الحين بس lacrimal sac and lacrimal gland. Which one is the intraorbital? Which one is extraorbital? What defines intra or extraorbital, Said? Okay, orbital septum. So anything anterior to that is extraorbital. Anything posterior to that. So lacrimal sac is extraorbital. That's why Dacyrops, although it's reported, but rarely you get orbital cellulitis. There are reports, of course, but generally speaking. However, when you have a an infectious or inflammatory process, the lacrimal gland, this is orbital process. So lacrimal gland is near here. So you mentioned the posterior extent. What else? So it's very important not to forget the lymph nodes, please. I always notice that during the exam, they tend to forget it. So we're gonna come to the lymph node. So you just draw an imaginary line, and basically this and this goes to the submandibular, and here goes to the preauricular. So as you all know, الإكسجين يكون 3 to 4 millimeter free margin. Do you know any other treatment modalities? Let's say this patient is 90 years old, dementic, very difficult to examine, not cooperative, and let's say that there is orbital extension, sinus extension, maxillary sinus. This is, by the way, a true case. Would you do surgery for this patient? Especially that you're going to do flabs and grafts, and you're going to remove suture, you're going to remove pressure dressing. Are you going to do that? Like what? Other than the medication you have in mind? Okay. So anyone knows the medication? Okay. So MENINGIOMA, interferon, and it's very important to know the radiotherapy side effect. Also, it's a common oral exam question. Okay, so just to go quickly through the history taking, as you mentioned, active complaint, onset, anesthesia, frequent sun exposure, and history of smoking, immunosuppression. Specific genetic syndromes, it's mostly MCQ question, but it's good to know, like xeroderma pigmentosa. And what else? Is there any syndrome in mind that is common and can cause skin malignancy? Okay. So the types, also it's important: nodular, ulcerative, morphiform, pigmented. Have a look on the pictures of each one. In our population, mostly it's pigmented. The previous slide, it was ulcerative. So as you know, I'm going to go through just quickly because we have a lot of things to cover. The medial canthus is the poorest prognosis because it's deep, tend to penetrate deep, and it's in close proximity to the canal care system. So this is the lymph node, as you mentioned. So this is less than a third of defect. How would you repair this one? And if there is a little bit of tightness? لا ترى strip, you tighten the lid. You mean something else, something in the lateral canthus. What's that? Because you want to bring this to the here. So what will you do here? And you should say it على طول, ها? عشان. So as you mentioned, less than 1/3. Again, because we have short time and I have a clinic. So this patient, again, the other history is that recurrent chalazion and infection and the eyelid at the same time, at the same site. In an elderly patient, you think of sebaceous cell carcinoma. So basically, you do incisional or shape biopsy and confirm the diagnosis. The excision, it's okay, Said, I will send it to you. You don't need to. الإكسجين يكون 5 ملم wider than basal cell carcinoma. You don't need to mention map biopsy unless you get asked about map biopsy. Poor prognostic factors is mostly of MCQ question. But this is map biopsy. There are different ways to do map biopsy, but this is from Shields and Shields. So as you can see, the dot is the palpebral, and this one is the forniceal, and this is the bulbar. You plot it the same way as the picture. And the reason you do that, because of pagetoid spread. Again, remember when we said about key buzzwords? So pagetoid spread. So a trick question is, when you get, let's say that you removed this and it's negative, are you going to be happy? They're trying to ask you, and they're trying to know if you know pagetoid spread. Okay. Okay, Abdurrahman, this is more extensive. So what's the direct closure and catheter catholysis didn't work in this patient? What's the other option? Okay. Nothing in your mind? طيب أروى محمد. So tensile flap, of course, when you do tensile flap, you need to do catheter catholysis. So because the defect is in the lower lid, it's drawn the other way around, and in the lower lid, it's the other way around also. Okay. طيب. So again, tensile flap for moderate defect. If you have also the previous one and the one before that was full thickness. So again, you have to mention that this is involving anterior and posterior lamella. It's a full thickness. For example, this one is anterior lamella. So either you can undermine from here and close, or you place the skin graft. Important to know where can you harvest the skin graft? As you all know, either the same or contralateral upper eyelid, especially in elderly patient, pre and post auricular, supraclavicular, not clavicular, supraclavicular, and the upper arm. This is the area where you can harvest full thickness skin graft. So, as you all know, full thickness, more than 2/3 or 100%, you do Hughes flap, because in the lower lid, Hughes flap. So basically, you take the tarsus. You don't need to know about how many millimeters, and this is fairly level. So you can see here they suture the tarsal plate, and in this way they corrected the posterior lamella. Now you need to do the anterior lamella. So either you do a skin graft. I usually, when you do these patients, usually they are old, so they have a lot of redundancy. So you can do an advancement flap, huge undermining here, and you can suture it. So you're going to have two flaps. The upper eyelid, cutler beard. Knowing it alone should be enough. Again, another question, the key difference that in Hughes flap is replacing the posterior lamella, while in cutler beard, theoretically, you're replacing both lamellae, posterior and anterior. It's not that accurate for description, but basically, if you want to replace the tarsus here, there's a modified cutler beard. Either you replace it with ear cartilage, sclera, hard palate, tarsal plate from the other patient, from the other eye. You suture, you replace the tarsus, then you bring the flap and suture it. Of course, here the incision should be less than below 4 to 5 millimeter, so you will not injure the peripheral arcade. So this is mainly the I'll send you the slides, inshallah. So the goals, again, you can look it up, inshallah. I will send it to you. Would you like it in PDF or PowerPoint format? What's your preference? So briefly, ptosis, usually they don't bring it. They bring specific things in ptosis. We're gonna come across it. So congenital ptosis, this is a congenital ptosis. You can see that the elevator function is not normal usually. By normal, I mean more than 15 or 15 and above. And in down gaze, they have lid lag. And those who rotate with me, they know why they have lid lag. And these are the most important history taking. While in involutional, you can see the lid crease is higher here. And in down gaze, it's more ptotic due to disinsertion of the elevator. So now, what's important in ptosis is the pseudoptosis, the things that can kill the patient. So you have to know the causes of ptosis, neurogenic ptosis, all the causes you have to know it. Acquired ptosis, let's say in a patient who's 8 years old and started to have ptosis, is different than congenital. So now you're talking about, let's say that you're seeing a patient who's 8 years old and is having progressive ptosis with some limitation of extraocular motility, with some proximal myopathy. This is something that more dangerous than simple congenital. So what are the differential diagnoses that you should rule out in such scenario, Mohammad? What are the types of ptosis? Yeah. So basically what I'm asking is about chronic progressive ophthalmoplegia. So what are the differential diagnoses of chronic progressive ophthalmoplegia? So what are the names? Just give me names. Okay. Chronic progressive ophthalmoplegia, differential diagnosis. I gave you a specific scenario. You have this scenario. A child who's, let's say, 10 years old, progressive ptosis, started at the age of 8. And during examination, there are some limitation of extra motility. Bills is not good. And the patient has proximal myopathy, difficulty in holding, carrying things. In children, it's rare, but okay. One differential. Okay, what kind of element? There's muscular dystrophy is a general term. We need specific diseases. Anyone? Okay, and those who have Kearns-Sayre syndrome, what's the associated morbidity? More renal. Yeah, so cardiac conduction, or heart. So you need to involve an internist, a pediatrician, and cardiologist. This is something that can kill the patient. Okay, what else? So for the sake of time, we'll just... So this is from Wood's manual, okay? So Kearns-Sayre syndrome, as you mentioned, and also oculopharyngeal dystrophy. So it's important to ask about swallowing, eating. Mitochondrial myopathy is also I have a couple of cases of mitochondrial myopathy. So all of these differential are very important. So ptosis, usually simple ptosis will not come. The mechanical or the neurogenic or the progressive ophthalmoplegia usually is the high yield. So for example, this patient have ptosis and levator function is okay, lid crease is symmetrical. Whenever you find something that doesn't fit with the common ptosis, like involutional or congenital, you have to roll out mechanical, get your Hertel exophthalmometer, check the motility, check the pupil, see if it's progressive in history, all of this. For example, this patient had mechanical ptosis with orbital mass. Also, Dacyrops is common. So some examiners, they like to ask about Dacyrops. Where you go into details in ptosis, at the end, they will tell you the cause of Dacyrops. So flipping the lid margin, the eyelid, and diverting it is important. So Dacyrops, if it's small, observe. If it's large, you can just excise it. This is, as you know, the MRD1 is normal here, but you have dermatochalesis. So this is pseudoptosis. Also, it's important to know the differential diagnosis of ptosis, pseudoptosis. And these are the treatment scenarios that you should know about. Lymphoproliferative syndrome also is high yield in oral exam, specifically the association of premature ovarian failure. Okay, and not only they have amblyogenic, they don't have only occlusive amblyopia from ptosis. They common have strabismus and refractive error. So don't approach it as ptosis. Approach it as a pediatric station. You ask them about the prenatal. Ask you do cyclorefraction, dilated fundus exam. Okay. Entropion usually it's not a common oral exam, maybe in R2, but what you have to know that the upper eyelid, it's almost always cicatricial. Never mention that the upper eyelid is involutional. Almost never happen. Okay, moving to ectropion. So you can see that this is the shortened quaternial lamella with cicatricial ectropion. This is a spot diagnosis, lower motor neuron, because you have involvement the whole face. Again, for the sake of time, this is also some oculoplastician, they like this score. Okay. Herpes zoster also is common. You have to know the medication. You have to know Hutchinson sign. Don't forget to ask to examine the eye itself. Rolling out conjunctivitis, keratitis. On this exam for any theoretically progressive outer retinal necrosis. Canaliculitis, usually it's a bonus question, but it's good to know. There was a study in Cakish, maybe I mentioned this before, that they found that the most common is strep followed by staph. Arguably, you can see that actinomyces israeli has a biofilm and it's very thick. So you need to culture it for many weeks in order to confirm that it's actinomyces sometimes. So probably this is the outer bacteria that is in the biofilm of the concretion. So, but if you get someone from Cakish, you can just mention this. It's a good bonus. So dacrystitis, the red flag is you should interrogate. signs of malignancy or suspicious signs. There is bloody tears, palpable mass above the medial canthal tendon. You should think of, and also lymphadenopathy, you should think of other etiologies. For example, this is an ethmoidal mucocele. However, you should mention also if it's pulsatile, because meningoencephalocele can happen in this area. Lacrimal sac neoplasm is very important. If you have bloody tears and above medial canthal swelling, this patient you should treat aggressively with systemic antibiotic, and you can admit the patient because they are at risk of septicemia. They're usually, when you have babies, the first year of life who develop this, you need to be very cautious in order for them not to develop septicemia. Popular scenario, and recently I noticed they like a filler reaction scenario, and usually the hint is a history of non-surgical intervention. It's very important. You have to ask about the type of filler, and is it permanent or the usual hyaluronic acid. Fortunately, the permanent is not as common as, the past years. Maybe they were common, but صار عليها رقابة الحمد لله فقلت شوي. Now they have mainly complication of hyaluronic acid, but still it's very important to know. It's even a board exam question, this one. Going to trauma, so in those pictures you have to first mention, you need to rule out life-threatening injury, and rule out open globe. And you can see here the incision is medial to the punctum, so definitely you need to comment on the canalicular system. Here there is a fat prolapse and also medial to the punctum. So you have the canalicular system as well as the levator aponeurosis. And here also it's a full thickness. You can see even the bone. So don't forget about tetanus and systemic antibiotic. Types of stent, they like to ask about it. So either you have mono or bicanalicular. So what's the name of this one, AlRajeh? Is it mono or bicanalicular? بس في عندك اثنين. So it should be bi, no mono. Yeah, what's the name of this one? Okay, كويس. Ocular. بعدين بوجهي هذا تصير. طيب تمام. What about this one, Mohammad? This is monocanalicular. What's the name of this one? This is the same, بس جبت صورة أوضح. تمام. And this one, عبد الرحمن. أروى, what's this? طبعا close up. سعيد خان. تمام. And this one, because you can insert the suture, they call it the eye of the pigtail. So advantages of each one, of course, this and this, you can do it under local because you don't need to go through the nose. However, this one should it needs GA because you need to retrieve it from the nose. So again, I'm going to send you all of this. إنه صعب إني يعني بسبب إنه الوقت. تذكرون يمكن previous oral reviews قعدنا يمكن 3-4 ساعات, بس الحين إنه وقت محصور شوي. So retrobulbar hemorrhage is also important. This is from Will's manual. It's, I think, the best book that summarizes the treatment. This is a very important scenario, white-eyed blowout fracture. Very, very important. And the reason they call it trapdoor fracture, because the bone is very malleable in children. So the fracture happens and the entrapment happens at the same time, then the bone goes back because it's malleable in children. That's why they call it trapdoor. Okay. And it's one of the indication of immediate repair. So you need to know about this immediate repair. And this is from the academy. Another bonus question: the materials used, the implant material used for orbital floor. Always try to be systematic: pathogenous, allogenic, alloplastic, and permanent. This way you'll never forget the implants. Okay, going to thyroid eye disease. Obviously, this is active and this is not active. Usually you have, generally speaking, two types of thyroid eye disease: muscle dominant like this, or fat dominant. And the most commonly affected muscle is inferior and medial rectus. Another extra question that usually is commonly asked, that you have an orbital inflammation like this one, uni or bilateral, and you have involvement of superior rectus or lateral rectus. So obviously this is not thyroid eye disease. You need to think about other differentials. Regarding activity, not everyone asks about it, but the clinical activity score is important to know. The false positive, false negative, we covered it before. If you have a patient who have orbital congestion with high IOP and chemosis and episcleral injection at the lateral, at the recti muscle, this may be, those patients may score high in clinical activity score, while in fact they don't need steroid, they need orbital decompression. This is, they're not going to these details, but this is for your own practice. If they don't get, you can mention these parameters for active signs, as well as diplopia, specifically acute diplopia or progression of or worsening of diplopia, chemosis and lid edema, worsening of VA and visual field, increase of the angle of strabismus, and of course the optic nerve involvement. All of this is signs of activity. Okay, the popular scenario are straightforward like this one, or optic neuropathy, or exposure keratopathy with microbic otitis. These scenarios that you should know. Usually these three scenarios that comes in the oral exam. Okay. Orbital inflammation, approach it like orbital cellulitis in the exam. Of course, you can see there's no sinusitis. It's more acute than infectious etiology. And usually there is no fever, or there is no fever in those patients. So all of these are signs that you're in a station of orbital inflammation. And the examiner should guide you. مثل fungal يعني في keratitis في microbial keratitis. طيب. This is the algorithm. Again, differential diagnosis is very important to categorize it. So the previous patient, you can, they ask you either, this is from the American Academy. You say it's autoimmune, vasculitic entity like Wagner granulomatosis. You can mention the new name, and sarcoid, or idiopathic, which is a diagnosis of exclusion. And also you can mention IgG4, because it's not mentioned here. The labs covering the previously mentioned diagnoses However, if you have a lacrimal gland involvement, it's better if you include the connective tissue disorder serology. And if there's extra muscles involved, of course, you should include thyroid. This way, it's very systematic and it's easy to memorize. This is not common, but Tourette syndrome, they get you the same scenario with visual involvement, because it's involving the orbital apex with the enhancement of the cavernous sinus and cavernous and the dura around it. You should think of Tourette hunt, but I don't think they will. It's a high yield. This is a high yield topic, the orbital cellulitis. So again, the most common cause is sinusitis. That's why you have to mention the history. Examination, I covered for you all of the important parameters. How to follow up the patient, it's a common question. When you admit the patient, how would you follow the patient? It's very important. And always, you need to know about meningitis symptoms, like photophobia, head, neck stiffness. What else? Signs of cavernous sinus thrombosis. This is a bonus question usually. Those usually you don't need to, because usually you involve an infectious disease or of a clinical pharmacist in those patients. But you say that you're going to cover broad spectrum for gram-positive, negative, and of course, because there's sinusitis, you're going to cover anaerobes. I mentioned every scenario if there's no improvement. The other important thing you have to know that in less than 9 years, the study showed it's only one microbe, it's a single aerobic infection. However, it's polymicrobial more than 9 years. Complication, Gismoha, ocular orbital intracranial. This way, the examiner will know that you're systematic. Indication, not everyone agrees with this, but you can just say this is from the American Academy, because this is the reference for you as residents. Don't say large and non-medial. This is a general term. Just, but you know how you have to know all of the of these indication, and it's from the American Academy. Same scenario, but in all diabetic patient, always roll out Mucor, yeah. Dacroadenitis, again, you approach it as orbital cellulitis, and if it doesn't improve in 2 days, an adult, you should think of you should approach it as inflammatory. In children, it's mainly viral. So this is just to know the location of the pathology based on the displacement of the globe. And this is the onset. Usually a common MCQ question is the emphysema, that it happens in hours. However, days you have inflammatory, infectious, weeks, neoplasm comes into place, and so on. Again, another common question is Lipodermoid and fat prolapse, and the association of golden heart with Lipodermoid. This is the way to differentiate. It's commonly asked. So as you all know from previous reviews, Lipodermoid, usually it's there is firm adhesions with the conjunctiva and sclera, paler, firm, and it contains hair and can be keratinized, the conjunctiva. When you do retrobulgin, it's not prolapsing like the fat. And of course, the history. It's very important. It's present, it's a congenital. Okay. Usually, I don't like touching Lipodermoid, honestly, unless the patient is fully aware of complications. Again, this is mechanical ptosis with some dystopia. Scenario usually middle-aged female, and you can see the hyperostosis. Do you know what other entities causes hyperostosis? Anyone? Okay. Okay. تمام. So sphenoid meningioma, fibrous dysplasia, metastasis. Now, the most striking feature of this is it's not causing angulation or compression or displacement. It's molding around the globe. So right away, you're going to think about lymphoproliferative disorder. You're not going to say lymphoma right away. You have to say lymphoproliferative, and based on the biopsy, you will know which type. The key word here is that malignant is monoclonal in pathology, while the benign is polyclonal. So once you take the biopsy, based on that, they will tell you which type this is. So you don't say molding is lymphoma. No, it's a spectrum of lymphoproliferative disorder. Okay, so molding. All of this is theoretical. So so again, this is hyperostosis, or sorry, ground glass appearance in a child with signs of inflammation, mechanical ptosis, swelling. You know, this is fibrous dysplasia. It's a bonus question. I don't think it's fair to ask about. Maybe in board, but not in R2 or R3. So it's important to know why those patients develop vision loss. Associated syndrome, McConnell-Bright syndrome. We didn't need to go through that. Okay, another common scenario is pain and the temporal aspect of the in a child. All of this is very common scenarios. Back when this is all from my experience during residency. I know that each institute, they like specific questions. This review, maybe it's a little bit redundant for those who attended before. But trust me, this is a high yield from each institute. They like these diseases. ما حطيت أنا وش أحب أحبها كلها فتبي تجي منها يعني don't worry about it. This is very important. Child with superior temporal swelling and pain, proptosis. Yeah, they like it a lot. But again, you shouldn't jump. So it could be ruptured dermoid cyst, could be a hematoma from a recent trauma. What's very important is the age in each one, specifically the last two. So, do you know, Abdulaziz, the rhabdomyosarcoma, usually the average or the range of age? So, yeah, I expect it from 5 to 8 years. However, neuroblastoma, you expect it in the first 2 years. This helps you in MCQs and also in oral exam and in real life, طبعا. So this is the previous patient. You can see it's a histocytic lesion, and diabetes insipidus is commonly associated with it. Again, going to hyperostosis, this is a metastasis case, just to reiterate on the same point. Okay, so you can see this patient has inferior and medial proptosis. So the pathology is here laterally. So you can see well circumscribed mass. So usually the history is painless, progressive, slow growing, more than 1 year. We saw recently دكتورة يارا 10 years. شفنا صورة الناشونال اي دي. He had a little bit of dystopia like 8 years ago. So usually it's painless and slow growing. Treatment, you have to completely remove it. تذكر عبد الرحمن, the case we did. You have to remove it in total. So you won't have recurrence in the same area. She came again and I did MRI, it's completely gone. Recently I noticed they like to bring pathology slides. So it's good to revise it before the exam, especially for R3 and for the board exam. Okay, so you can see this Swiss cheese pattern in adenocystic carcinoma. Again, the history is much faster than pleomorphic, associated with pain and destruction of bone. Remember, we discussed this thoroughly, so you can read this pointer later when I send it to you. Neurofibromatosis, usually it's in a pediatric station. It's very important to know the criteria for each type. Also, optic nerve glioma is, I think it will come in pediatric station, not oculoplastic station. So this patient, 6 years old, and with the rapidly progressive swelling and proptosis, and you can see from the scenario, most likely this is rhabdomyosarcoma. And you see the difference here, how it's pushing the globe. It's not like lymphoma, where it's molding. So epithelial tumors of the lacrimal gland, soft tissue tumors, they tend to cause angulation to the globe. Pathology is important. You may get asked in the oral. So alveolar is aggressive, it's the worst prognosis, and usually it's in the inferior orbit. So management briefly, incision biopsy, debulk without causing any structural damage to or any morbidity to adjacent structure, and involvement of oncologist. You can read briefly about the intergroup rhabdomyosarcoma study group as a bonus question. So if you get a child, let's say 1-2 years, with ecchymosis, you think about neuroblastoma. Also, a very common question, differential diagnosis of well circumscribed tumors, and this is from Wells manual. Capillary Hemangioma ما في exam ما يخلو منها، إما جتك في الأوكيلو تجيك في البيدياتريك. Indication for treatment is very important. Honestly, propranolol, I think it's the mainstay treatment. It's such a effective and, alhamdulillah, safe drug, especially if you if you're working in a well-equipped hospital with good pediatric service. But you need to know about the other modalities of intervention. Do you know the mechanism of beta blocker? How does it obliterate the capillary hemangioma? Anyone? There are a couple of theories. You can look it up. Syndromes also, they like to ask about it. So hyperacute associated with the flu or viral infection, where the patient developed proptosis and swelling, you think of lymphangioma or lymphatocavenous. Buzzword is water fluid level. This is chocolate cyst. You can observe the patient as long as it's not causing any ocular morbidity like vision threatening, exposure keratopathy. And the mainstay of treatment is sclerotherapy, which is effective in macro, more than 2 centimeter. Micro, still, it's difficult to sclerose it. You need to know about the sclerotherapy medication. Anyone knows what are the sclerotherapy? Sclerosing agent, exit. Anyone? Okay, other than bleomycin. Okay. Okay. So, medical treatment. There have been some trials about sildenafil, sirolimus. You saw sirolimus من شاف معي patient. So far, sclerotherapy is the go-to therapy. Okay. So I added now. The last part is again. I'm sorry. عشان ضيق الوقت. Try to compress it. But don't worry, I'll send it to you. وإذا في أي شيء مثلا ما هو واضح, you can just contact me, ask me. I added the painful versus painless blind eye. So we're going to cover the anophthalmic socket now. So how would you approach each one, and what are the causes of each one, and what's the most important clinical exam, and what are the options? So we're going to cover that. This is from Bullseye Manual. I encourage you to read it. Such a nice summary of blind painful eye. So the causes can be end-stage glaucoma, corneal decompensation, chronic uveitis, hypotony, or of course endophthalmitis. So you're going to treat based on the cause of the pain, okay? So in painless blind eye, what are the surgical, let's say that, what's the most important clinical exam that you should do in the clinic? Anyone? So corneal sensation, and why is that? Because you're gonna fit the patient with prosthesis. So if there's no corneal sensation, or if the globe is microphthalmic or physical, you can just let the patient wear prosthesis without any surgical. Okay, let's say that there is a corneal sensation, and the eyes has sensory XT. What will you do for the patient? Patient wants to wear a fake eye or prosthesis and the corneal sensation. What will you do? Anyone? A conjunctival flap. Gunderson is specific, has specific technique, but in conjunctival flap, you just need to do 360 rheotomy, and you basically suture over the cornea, basically. So conjunctival flap to eliminate this corneal sensation. Then in a couple of weeks, you fit the patient with prosthesis. Let's say that the patient has good volume and it doesn't have sensory misalignment, but has corneal scarring. What will you do? What are the options? Again, we're starting with non-surgical, followed by surgical. A tinted contact lens, surgical, you can do corneal tattooing. تمام. If we're going to talk about volume, the only way to address it is with either large prosthesis, or you want to do evisceration or enucleation to put the largest implant that you can when there is issue with volume. So advantage of evisceration, it's technically faster, less disruption of orbital anatomy. The motility theoretically is better. And for endophthalmitis, it's enough to do evisceration in most cases. However, the disadvantage is the absolute indication of enucleation, which is intraocular tumors. Okay. The orbital implants, you have to know you don't need to know about silicone and PMMA, but you need to know that there is integrated and non-integrated, or porous or non-porous. So hydroxyapatite is porous. However, silicone and PMMA is non-porous. So you can see that this is silicone, hydroxyapatite is porous, and this is a larger silicone. Nobody, I think, is doing PIGS anymore because it was causing pyogenic granuloma. So exentration, these are the indication of exentration, not commonly asked. So what about the complication that can happen? We already covered pyogenic granuloma. Anyone knows what's this? This is post evisceration, and the patient was doing fine and wearing the prosthesis, and then it became unstable, kept falling, and gets pushed by this cyst. So what's Symblepharon? No, this is cyst. You can see it's containing fluid. So this is a conjunctival or inclusion cyst or tenon cyst. So anyone knows why this happened? Yes, excellent. So you embed the conjunctiva inside the closure. Okay, giant papillary conjunctivitis also is one of the complications. You can see the asymmetry here. There is the superior sulcus is deep. Do you know how to address this one? Let's start with non-surgical. So either larger prosthesis with superior like plate, so it will fill this one. Surgical factory, you mean the medial to the maybe, or you can place fat, dermis fat graft. But again, the asymmetry, the eyelid contour, it's mentioned. It's a theoretical. Theoretically, it's one of the mentioned known treatments. But yeah, what else? Surgical. So maybe the implant itself is small. Maybe it's 14, 16 millimeter. You can replace it with something bigger, like 20 or 22. Or you can place orbital floor implant to push the whole orbital content superiorly. So this is extrusion. So do you know what's the implant here? Hey, okay. So what's the treatment for implant exposure? So scleral patch graft and suturing the conj over it. Basically, this is the short answer. Here you can see that there is some symblepharon with contracted socket, and the treatment for this is what? Okay, when you release it, you're gonna replace it. You should replace it, otherwise it will recur again. What's the? How can you replace it with what? Mucous membrane ممكن. What else? Mucous membrane graft. Okay, I think that's it. يعني ربع ساعة زيادة. Do you have any question? Again, بسبب انه الوقت ضيق برسل لكم السلايد. So it will be a reference. I don't think I can add in future review لأنه أحس إني أكثر مرة قدمته وما في شيء يعني. Probably in the future it's good to have someone else and maybe they have different perspective and maybe they can add more. I'm sure no. What I know, you know, inshallah. طيب, any question? Okay, so we'll conclude. Okay, let's see. Sure. Anyone from the attendees have a question? ما في أحد عنده سؤال.